Okay, recording has started. This lecture is the second part series in burns. And as you can see, there's a whole heck of a lot on burns in your textbook. I don't really deviate much from the textbook. And ATI has an excellent, I think it's chapter 75 presentation on burns. So I would suggest that you look at that also. I want to test your knowledge from what you learned in part 1. So what type of burns would result from exposure to heat? And it can either be dry or moist.
Thermal.
Very good. Chemical burns result from direct contact between the skin and certain what?
Is it alkaline?
Alkaline is one of them.
And acid?
Acid is the other.
Inorganic.
Organic compound.
Yes, organic compounds. And that would be something you would see in pesticides or for lawn care products, things like that. For all chemical burns, the severity of the injury is directly related to what? So it would be the type and concentration of the chemical agent. And we know that alkaline agents are more severe than acids. And then again, the concentration. So the higher concentration, say hydrochloric acid, the concentration of the acid in that compound would increase the severity of the injury. What else would be directly related? The mechanism of action, whether you're laying in a pool of an acid or someone throws it in your eyes, the duration of contact, and then the amount of body surface exposed. An example of direct current is what?
Would that be a lightning strike?
Yes, it would. And we talk about the flashover effect of lightning, where the bolt doesn't directly hit you, but it hits somewhere proximal to where you're standing or sitting, and it travels over the moist areas of your body, and that's called the flashover effect. An example of alternating current would be what?
So
That
like household electricity.
Yes, it's what you would find in most households. And we know with this type of current, these repeated electrical surges can lead to tectonic muscle contractions. And that, and you've probably all seen that cartoon where the rabbit or whatever gets his hands caught on an electrical outlet and he can't let go, and you see his hair going. So that means when you make that direct contact to that alternating current, it's very hard to release your grip on it, and that increases the duration of the contact. When we talk about radiation burns, they're usually associated with what? Usually sunburn. And so superficial sunburn or treatment for cancer. You see the radiation burns from radiation treatments, but extensive exposure to radiation would be exposure with a nuclear reactor. And then tissue damage following a burn is going to be determined by 2 factors. And it would be anyone?
The depth of the burn?
Yes, and the
percentage of body.
Exactly, the extent of body surface involved. So let's get to learning. Treatment of burns is going to depend basically on the amount of body surface area involved. We said the depth of the skin damage and the location of the burn. Burns that involve the airway would require more attention than those that involve the extremities. So treatment is often begins at the scene where it could be provided by family members, EMS, or specially trained personnel in an occupational setting. And then later, the patient may receive advanced treatment in an outpatient facility, a hospital, or burn center. Minor burns, and we're all have some reference to a minor burn, and they're usually treated on an outpatient basis. And the goal of therapy for a minor burn is to promote wound healing, eliminate discomfort, maintain mobility, and prevent infection. Now, we said sunburn is one of the most common types of minor burns, and nursing interventions related to sunburn usually consist of applying mild lotions, increasing liquid intake, and maintaining warmth. We've all had sunburns, and you have that feeling where you're very cold, so you cover up. The best thing to do, again, is to increase that liquid intake. Be aware that older adults and children, you want to monitor them for signs and symptoms of dehydration. If blistering is present, the blisters can either be left intact or debrided. Now, debridement is that process of removing necrotic material, and necrotic material can include both loose tissue, wound debris, or eschar from the wound. Follow-up care for minor burn injuries usually involves twice daily cleansing with perhaps maybe an application of a topical ointment. You want to continue range of motion for any affected joints. And again, keep all weekly appointments until the wound heals. The course of treatment for a severe burn injury is divided into 3 stages: the emergent resuscitative, the acute, and third and lastly, the rehabilitative. Just keep in mind that the treatment of burn injuries is dynamic. So in many cases, the clinical stage that the patient is in is not clearly delineated. So they may progress from the emergent resuscitative to the acute, and somewhere in that acute facility, they may become emergent or resuscitative again. Again, same thing holds true with rehabilitative. There may be some glitch in the system. They develop this massive infection, and now they're emergent resuscitative again. But what we're going to talk about in the next several slides is the typical presentation or progression of a patient with a severe burn injury. And it may not apply to some burn patients. So let's start with the emergent resuscitative, and that treatment is usually at the scene, and it includes measures to limit the severity of the burn and to support vital functions. The first thing you want to do is secure the scene for safety. And secondly, we want to stop the burning process. With thermal burns that are caused by dry heat, like fire, you want to smother the inflamed clothing or throw water at it. You want to help that patient to remember from grade school, stop, drop, and roll, still pertinent today. And once you have extinguished the fire, we want to cover the patient to prevent hypothermia. If the thermal burn is caused by moist heat, say steam, you want to lavage the area with cool water. We never use ice for cooling because ice causes vasoconstriction. For chemical burns, we want to immediately remove the patient's clothing and use a shower or a hose to lavage the involved area thoroughly for a minimum of 20 minutes. Now, I don't like to give time or minutes out and say you have to do it for 20, but I can tell you from experience, it is truly a minimum of 20 minutes where we're doing a lavage on chemical burns. Be aware that many chemicals come in powder form. So you want to remove as much dry chemical as possible from the skin before you flush the surface with water. Again, poison control is always a resource when you require consultation about appropriate treatment. The rescuer should wear protective clothing during this portion of care for personal protection from chemical exposure. Chemicals splashed in or near the eye require immediate eye irrigation with clean, cool water or saline solution. And so why I say clear, cool water as opposed to saline, remember this could be out in the community and your first responders may not have a saline solution with them. So clean, cool water would be something they would use. We'll move on to electrical burns. Now they pose the potential of serious harm to both the rescuer and the patient. Before assisting the patient, and we're talking again out in the community, you want to ensure that the source of the electrical current has been disconnected. If you are unable to do this, you want to move the patient away from the energy source using a non-conductive device, such as a wooden broomstick. Once removed from the source of the electrical current, you want to quickly assess that patient for cardiac and respiratory function. If indicated, we start CPR. Remember, this patient could be a spinal cord injury secondary to that forceful contraction of the muscles of the neck and back during that exposure to the current. So if it's possible, you place a cervical collar on that patient and you transport them on a spinal board. Radiation burns are usually minor and only involve the epidermal layer of the skin. So treatment with radiation burns is going to focus on promoting wound healing. For severe radiation burns, there's trained personnel, your hazmat teams, and they first need to secure the scene for safety. And interventions with these severe radiation burns would be aimed at shielding, establishing distance, and limiting the time of exposure to the radioactive source. So once the burning process has been stopped, emergency personnel will take steps to support the patient's respiratory and circulatory function. So we follow our ABCDE bundle of trauma care. For non-superficial burns, so that would be any burn that involves a deeper, other than the superficial layer of the skin. So non-superficial burns involving more than 15% of the patient's total body surface area, emergency personnel will initiate fluid replacement therapy. So you're going to say how the emergency personnel know that it's more than 15%. And the best is that they use the Parkland formula, and we'll talk more about it, or the rule of nines. And it's a very easy way to look at a person's burns and guess what the percentage is. Again, we want to cover that patient to maintain their body temperature. We want to prevent wound contamination and tissue damage. If the patient is wearing any restrictive clothing or jewelry, you should remove it immediately. And you'll see that patients that come in from the scene, They will cut off rings or bracelets because they know that very shortly there's going to be some edema in those burned areas, and we're going to have this massive swelling, and then those rings or jewelry or whatever are going to act as a tourniquet. And as you can see in the pictures down at the bottom, we see what happens when you leave a ring on and a person's hand has swelled because of burn injury or fluid movement. So emergency personnel at the scene or on arrival to the hospital, we're going to evaluate the patient's status by following that ABCDE of trauma care. Intubation is indicated for all patients that have burns to the face, the chest, or the neck. Soot in the airway or singed facial hair is an indication of an inhalation injury. If endotracheal intubation is not indicated, we will administer 100% oxygen via a non-rebreather mask until it has been established that carbon monoxide poisoning is not a factor. Remember, your pulse oximetry, it cannot distinguish between carboxyhemoglobin or oxyhemoglobin. So how do we monitor carboxyhemoglobin levels? We do a serum test for carboxyhemoglobin, and a value greater than 9-11% would tell us positive. And I'll talk a little bit more about that in the case study that we're going to go through. But keep in mind that a carboxyhemoglobin level or value greater than 15% may require a hyperbaric chamber. Now, I know Christiana doesn't have one. I would believe Chester Crozer does. I am positive that Penn has one because I know we have sent patients up to Penn. An arterial line is often placed in a patient with a major burn for continuous assessment of the ABGs. And the reason why we monitor ABGs is because that is what's going to dictate our choice of oxygen therapy. Circulatory support and fluid resuscitation. So fluid resuscitation is the administration of IV fluids to restore the circulating blood volume during the acute period of increasing capillary permeability. We are attempting to counteract the effects of burn shock. So what that means is during this acute period in the first 24 to 48 hours, you're going to see this rapid fluid shift, and it's because of the capillaries, their increased permeability. So fluid shifts from the vessels and into the interstitial departments. So now we have our circulatory support, our volume in the vessels is very diminished. So we have to restore that and support that. So the American Burn Association practice guidelines recommend fluid replacement to any patient with non-superficial burns that involve 15% or more of total body surface area. So during fluid resuscitation, crystalloid fluids are administered through a large bore IV, and it's preferably inserted through unburned skin. Now that if you don't have an area that is unburned, that doesn't mean you can't still insert that IV. Again, it's preferred to look for unburned, but if you don't have a choice, you go with your best possible. If that total body surface area is greater than 40%, they will look for 2 large bore IVs. And when I say large bore IVs, they want a 14 to a 16 gauge. I know an 18 works just as well, but for the American Burn Association's recommendation, a large bore would consist of a 14 or a 16 gauge. I did mention the lactated ringers, and we want it warmed if at all possible during that first 24 hours. The reason why we warm it is because these patients, again, are susceptible to hyperthermia, and just 1 liter of room temperature fluids can drop their body temperature 1 degree. So we use lactated ringers because it most closely approximates the body's extracellular fluid. So there are several formulas used to replace fluid loss, including Parkland. There's a revised Parkland, and then there's a modified Army Brook formula. The Parkland formula that is posted in the supplemental material on D2L is the formula that we will use in this course. And we use that because that is the formula that you will see on your NCLEX exam, and ATI also uses that. Pediatric patients. So I'm going to mention this here briefly because as an entry-level nurse, you will not be required to do fluid resuscitation for a pediatric patient. That is an advanced level of care. But the reason why I mention it here is because you need to know that they require a different approach. Pediatric patients require maintenance fluids in addition to the calculated fluid resuscitation volume. And this fluid should contain dextrose because of their decreased glycogen stores compared with adults. So 2 things, they require additional fluids after the resuscitation fluids, and those fluids should contain dextrose. The Galveston formula is a more accurate indication of initial fluid volume resuscitation. However, I only mention it because that is what you would see in that advanced level of care for a pediatric patient. You would see the Galveston. So I mentioned briefly about this hypovolemic shock or this movement of fluids. So within minutes after a major burn injury, a massive amount of fluid shifts from the intracellular and the intravascular compartments into the interstitium. So you've all seen blisters that form after a contact burn or a severe sunburn. Well, this is kind of a fluid shift, but on a huge scale. And this shift is a type of hypovolemic shock called burn shock. And this will continue until capillary integrity is restored. And it usually about 24 to 36 hours after the injury, you will see capillary being restored and the fluid shifting back. But in that initial period, we are aware that there's fluid leaking from these capillaries into the interstitium, usually located at the wound site. But when it is a large body surface area involved, then we have a large area where we have this leaking capillaries and this increased fluid volume in the interstitial. The escape, again, of these plasma proteins and sodium into the interstitium is also going to enhance the edema formation. So not only do we have the fluid moving into the interstitium, but with that fluid goes those large plasma proteins and your sodium. And where sodium goes, fluid follows. Where these large plasma proteins go, fluid follows. So what vital signs do you expect to see? Anyone? What would your blood pressure do in this initial period?
Low blood pressure.
Increase.
Very good. Low blood pressure. And what's your heart going to do?
Trying to compensate, it will be higher.
Very good. So it kind of goes along with your shock lecture on hypovolemic shock. Although we're not really losing volume because they're bleeding out, we're losing volume because of that capillary integrity. So let's go back over some of the things we just talked about. The vascular system attempts to compensate for fluid loss by doing what? What do you suppose that your veins and your vessels are going to do when it recognizes that it's losing fluid?
Vasodilate.
Dilate or constrict. Think about it. You're losing fluid. You want to compensate.
Oh, constrict.
Yes, we would constrict because that would restore more volume in the vessels. So edema at the site of the burn is going to impair what?
Peripheral circulation.
Very good. So think about that. If you have this large burn, say both of your legs are burned, and so we have this fluid shift, right? These impaired capillaries. So now we have the edema at the burn, and now we have an impaired circulation because of that massive amount of fluid. That is going to result in necrosis of that underlying tissue. That's why burns are very, they're very high with infection and skin impairment. Potassium ions leave the intercellular compartment. So if they leave the intercellular compartment, they go to the intervascular. So now we have potassium ions that should be in the cells and they're in the intervascular. So now they put the patient at risk for what? Cardiac what?
Dyspnea.
Very good. Oh, and actually I said that wrong. So let's go back and say it again. They leave the intercellular compartment and they leave the intervascular, right? Go into the interstitial. So now we put them at risk for hypokalemia because they're no longer potassium ions in the serum. Burn shock usually resolves when capillary integrity is restored. And it's usually within how many hours?
24 to 36.
Very good. So as that fluid shifts back into the intervascular and into the intercellular departments, the patient's blood pressure should rise. Their cardiac output would also increase, and their urinary output improves. Just remember during this stage that extra cardiac workload, right? Because we've given lots of fluids to combat it, and now the fluids are shifting back in addition to the extra fluids. So that could predispose older patients or patients with cardiovascular disease to what do you think would happen with them? So if I gave you lots of fluids,
Fluid volume excess.
that's excess. Very good. That fluid volume overload. So you've got to be really careful with these patients, and we have to make sure that we're diuresing that fluid once it shifts back in. So there's multiple formulas used as guidelines for the volume of fluid to be infused over the first 24 hours. The Parkland formula and its variations are the universal standards for adults. And as I said in the previous slide, pediatric patients require a different approach. They, again, require maintenance fluids in addition to the calculated fluid resuscitation volume. And this fluid should contain dextrose because of their decreased glycogen stores compared with adults. So let's take a look at this Parkland formula. And you know how we tell you there are certain labs you need to know? Well, there are certain formulas you also need to know when you take your boards. And it's kind of an easy formula. 4 milliliters of fluid times the total body surface area times the total body weight. And with Parkland, 50% is going to be given in the first 8 hours, and the additional 50% will give in the next 16 hours. Now, some of you who work in specialized areas are going to say, oh, Mrs. Loveheed, we don't use 4 anymore. We use 2, and that is true. That is current practice. They found that 4 milliliters was excessive, and patients were showing up at burn centers blown up like ticks because of all the fluid that we had given. But for your purposes and for your testing purposes with NCLEX, we are still under the old 4 milliliters. So there's, first thing I want to know is, I'm going to go back here, is we want to calculate the total body surface area. Now, how do we do that? And that is the rule of 9s. And so we're going to go over this step by step. So this is the rule of 9s. There are several methods to determine this total body surface area, but this rule of 9s is really a quick method of estimation. And again, it's used very frequently in the pre-hospital and the emergency care phases. In the rule of 9s, the adult body is divided into 5 surface areas. We have the head, and that includes the face. And that is divided into 4.5 for the front and 4.5 for the back. We have the trunk. And so some of you are going to say, does the trunk include the abdomen, or the abdomen includes the trunk? When I say the word trunk to you, that's 18%. So I wouldn't say, I wouldn't split that up. The arms, again, the legs, and then that perineum is 1%. So these percentages equal or total a sum of 9 are assigned to each of these body areas. There are different percentages assigned for children. Again, let's kind of disregard children at this point. Let's try calculating the total body surface area of a burn patient using the rule of 9s. So you have a 25-year-old female patient. She has sustained burns to the back of the right arm, the posterior trunk, the front of the left leg, the anterior head and neck, and the perineum. So let's start one by one. I said the back of the right arm. So that is what? What percentage?
4.5.
Good. The posterior trunk.
18.
18, good. The front of the left leg.
9.
Good. Anterior head and neck.
4.5.
9.
4.5. Anterior, right? And perineum.
1.
1. So that should equal. Anyone do it? I have 37, right? 4.5, 18, 9, 4.5, and 1. Let's try another one. A 35-year-old male patient has full thickness burns to the anterior and posterior head and neck, the front of the left leg, and the perineum. So the anterior and posterior head and neck is going to give you what? 9, good. The front of the left leg is going to give you,
4.5.
9,
and then the perineum is going to give you,
1.
So 9 plus 1 is
19.
19.
good. And remember, don't get caught up. Only partial and full thickness burns are included in this estimation. If I give you a sunburn, you are not using the rule of nines or fluid resuscitation because sunburns are superficial. Here's another one. You have a 66-year-old female patient with deep partial thickness burns to both legs on the back, both arms on the front and back, and the front and back of the head and the neck. Using the rule of nines, calculate the total body surface area percentage that is burned. So both legs on the back are going to give me
18.
36.
So both legs on the back are going to give me
18.
18.
18. The front and back of the trunk.
That's 36.
Is that the
36. I heard that.
36?
So, yeah. Both arms on the front and the back.
9.
Both
Oh,
arms.
both.
18.
on
18.
Good. And the front.
72.
Yeah. And the front and the back of the head and the neck.
9.
9. So you would have 18 plus 36 plus 18 plus 9, and you should get 81%.
81.
That is a huge percentage of burn area. That patient is really at high risk for just not making it. I mean, that's huge. So we'll try another one. A 45-year-old female patient has superficial partial thickness burns on the posterior head and neck. I have a front of the left arm, the front and back of the right arm, posterior trunk, front and back. I have to move my thing because I can't read it. Okay, front and back of the left leg and back of the right leg. The patient weighs 91 kilos. Using the Parkland formula to calculate the total amount of lactated ringers that we'll be giving over the next 24 hours. So I'm going to tell you right here that the total body surface area on this patient affected would be 63. So I'm going to take, if I use the formula, I'm going to take 4 times 63% times their body weight in kilograms, and that would be 91. So I would come out with 22,932 milliliters. So think about that. That's like 22 liters of fluid in 24 hours that we're giving this patient. That is a lot of fluid. 50% is going to be given in the first 8 hours, and then 50% it will be given in the next 16 hours. So it's not unusual for you to see these huge amounts of fluids given in that first 24 hours. Would I give you something this complicated on a test? Absolutely not. The purpose is that you understand how we calculate total burn surface area and fluid resuscitation in that first 24 hours. So how do we know if our fluid resuscitation measures are sufficient or not? Well, hourly urine output is considered the most effective indicator of fluid resuscitation. And I'll say it again, hourly urine output is considered the most effective indicator of fluid resuscitation. Now, patients with a major electrical injury are an exception to these rules. And why do you suppose that is? Anyone ever see a lightning strike, a victim? So it would be sort of like a gunshot victim, where you would see an entry and an exit wound, but underneath what you see externally, there's a lot of damage. And it would be very difficult for you to estimate the extent or volume of tissue damage. So we often underestimate their fluid requirements. So the goal, again, of fluid resuscitation is to maintain urine output at 1 milliliter per kilogram per hour in adult patients and 1.5 milliliters per kilogram per hour in pediatric. I put the pediatric up there just so you would be able to see that they require more, but I don't need you to memorize what a pediatric patient needs. But you should know that with adults, it should be 0.5 to 1 milliliter per kilogram per hour urine output. With our electrical burn patients, again, if we can't accurately estimate that area of burn, we're going to be looking at urine output because we want to keep it within that range. Another indicator, but not as effective, would be heart rate. So if the fluid resuscitation is adequate, what would you expect the heart rate to be?
110.
I'm sorry, I didn't hear you. We would expect the heart rate to be less than 110, right? Because the heart is not compensating for that fluid volume deficit. It's worked itself out. But then again, I want you to remember, and why I say it's not the most accurate indicator, because there's many reasons why heart rate can be elevated, especially in a burn patient. Fear could do it, anxiety, pain. Blood pressure changes are less reliable because significant hypotension does not develop until 30% of volume is lost due to compensatory mechanisms. So the number one would be urine output. We can look at blood pressure, we can look at heart rate, but just know they're not as reliable. I put at some point during the acute or the emergency phase, there's going to be consideration to transfer to a specialized burn unit. And they may do that right from the scene if they're close in proximity to the unit. However, again, stabilization is going to be the first priorities. So you're going to go A, B, C, D, E first, and then you transfer. So we all know that we are close to Chester Crozier burn unit. However, if there is a significant burn here in Newcastle County or Kent or Sussex County, they will come to us first. They will not bypass a level 1 trauma center and go right to to Crozier, because they have to stabilize first. Now, I can tell you, once they come through our doors at Christiana, we're on the phone with Crozier looking to initiate transport, but we do stabilize first and then transport, because again, that is a specialized care. Do you have to memorize these? No. I did put on D2L a copy of the referral criteria, and I can honestly say they are quick to move burn patients. So there's 3 surgical interventions commonly used to manage burns. So on a burn, eschar, that's that dry dead skin, and you can see it. If it forms circumventrally around a torso of an extremity, it can act like a tourniquet and will impair circulation. So if you leave it unchecked, it can lead to gangrene. Remember, all that dead tissue is not promoting wound healing, so the underlying tissue becomes gangrenous. And eschar-otomy removes the eschar with a scalpel or electrocautery, and they use sterile surgical incision, as you can see in this top right picture, these longitudinal incisions, and they're made along the extremity or the trunk, and that releases that taut skin and it allows for edema formation. And it's the same concept as a fasciotomy where the compartment syndrome. This is basically a type of compartment syndrome because we're not allowing for edema. So I have seen this happen when patients come in with these severe burns. They will basically take a scalpel and make these cuts here, allowing for this edema to form. Same thing with your head injury patients, right? When we know that we have a bleed or we have a head injury, we want to allow for that edema formation. So they remove a piece of the skull and implant it either in their abdomen or they store it at a site. But again, it's just allowing for that edema formation. Surgical debridement is the process of thoroughly cleaning the wound and removing all thickened skin or callus, any infected or necrotic tissue, foreign debris, and residual material from dressings. It's very painful. Autografting is a procedure in which a part of the patient's healthy skin is removed and used to affect permanent skin coverage over a wound area. And so this is like your skin grafting. And some of those students here who are on a surgical unit have seen where wounds are so massive and you can't get the edges of them to approximate. They will use a skin graft to close that wound. So after the autograft is applied, that means we've taken it from the patient, right? You want to, and usually it's from a thickened area, you'll see the top of the interior, the thigh. So once it's removed, you immobilize the site and you want to assess daily the site where you placed it for evidence of adherence. We will resume our range of motion exercises 5 days post graft, right? An allograft is human skin that is harvested from cadavers. So with someone with massive burns, they may not have any viable skin to be used as a graft, so they can use an allograft. But be aware that rejection is a concern. And so rejection is usually demonstrated within 14 to 21 days following application. However, it does act as a covering and it does reduce infection and promote healing. A heterograft is skin obtained from an animal and it's usually a pig. There's high rates of infection with this type of graft. Cultural epithelial autografting is a technique in which skin cells are removed from unburned sites. They mince them, place them in a culture medium for growth. And with this technique, enough skin can be grown in a period of 3 to 4 weeks to cover an entire human body. The cells are then prepared in sheets and attached to petroleum gauze backing and applied to the wound site. Again, problems with infection and lack of attachment are possibilities. And we'll talk a little bit more about this when we do our short case study. All partial thickness burns, along with extensive superficial burns, cause excruciating pain. During the acute stage of burn injury, invasive procedures and exposed nerve endings dictate the need for narcotic pain relief. Wound care and physical therapy will also contribute to pain. So you want to make sure if they're going to be doing a debridement or the patient's going to physical therapy that you pre-medicate them for pain. Again, increased anxiety is known to increase the patient's perception of pain. In the initial phases of care, Opioid analgesics such as morphine, oxycodone, fentanyl, Dilaudid are the best way to manage pain. We want to administer them IV in the emergent or acute stage of a burn because of decreased circulation and absorption of medications. So IV is better than oral because of that decreased circulation and absorption of those oral meds. So we go to IV first in that first emergent or acute stage. And as I said, we avoid oral administration until the patient is hemodynamically stable with normal gastric emptying. Again, we said administer pain medication before painful procedures, and a PCA pump may be appropriate in some cases. Systemic infection is the most common cause of mortality in patients with major burns. Patients with major burns are given prophylactic antibiotics. Systemic antibiotics are also given in the immediate preoperative and postoperative periods. Topical antimicrobial therapy may be used to eliminate infection on the surface of the burn, and it is not applied until the patient is at a burn unit. So if you're at a level 1 trauma center or at any hospital where a burn patient comes in, you will start those prophylactic antibiotics, but you will not start with the topical antibiotics. That's more specialized. The choice of that topical antibiotic is based on the extent of the wound, the presence of identified bacterial organisms, right? They're going to culture it. The method that they treat it, either an open to air or they treat it with a dressing applied, and then that patient's response to therapy. So as you can see from what I just said, that is specialized, and that would be a treatment that you would see at a burn center. Tetanus prophylaxis is administered IM as soon as possible to prevent Clostridium tetani infection. And so any patient that comes in with a burn, we get that, and of course nurses like to be snarky, and they'll say, we'll give that life-saving tetanus shot. And truly with a burn patient, it's important that they get it because they are at high risk for this Clostridium tetani infection. So if you don't know their patient's tetanus status, you're going to give the medication by an IM injection. If their tetanus immunization is greater than 5 years, then you can give the booster. Patients with burn injuries are hyperacidic, and measures to control this must be implemented to prevent a curling ulcer, also known as a stress ulcer. So you might have seen this if you're on a surgical unit. Patients who are having GI surgery are put on a prophylactic histamine H2 blocker, and it is to prevent these stress ulcers. And as I just said, they'll give a histamine H2 blocker or a proton pump inhibitor. We give them intravenously via IV push or a continuous infusion. And then as soon as bowel sounds become audible, the patient is placed on a PO antacid regimen. So the goal of wound management is to close the wound within 5 days after the burn. And so that kind of makes sense when we talk about grafting and then wound vacs. You know, a wound vac, what a wound vac does, it actually pulls the edges of the skin around and attempts to close the wound. And that's why they're so effective, is because closing the wound is the best management. So to achieve this goal with burn patients, the healthcare team has to prevent and treat infections through daily topical wound care, wound monitoring, and wound incision and closure. And that treatment includes debridement, and the use of dressings. So necrotic tissue that remains in the wound has to be removed by one of three methods. And this is that surgical debridement, enzymatic debridement, or mechanical debridement. So I talked a little bit about surgical debridement in the previous slide, but to refresh your memory, surgical debridement is the cutting away of necrotic tissue. Mechanical debridement also removes dead tissue, but removal is done by application of those wet to dry or wet to moist dressings. So you've probably all were educated with wet to dry, and that's what we call a mechanical debridement. It's a very simple method. It can cause a lot of pain, and it can potentially damage granulation tissue. Hydrotherapy is a type of mechanical debridement, and we use that to prevent those problems that I just said. So hydrotherapy can be done in an immersion tank, as you see in the picture to the right, in a shower or on a spray table. During hydrotherapy, the burn is gently washed with a wound cleanser, and as you can see, they may be washing there, and that allows them to remove the dead skin and separate the eschar. The solution is then rinsed off with warm saline or tap water. Blistered skin is grabbed with dry gauze and gently removed. The edges of a blister or eschar are trimmed with blunt scissors, and then the wound is covered with a topical antimicrobial agent. So this would be something that you would do daily for a patient. And with debridement too, it would maybe once or twice daily, but no more than that. Can you imagine how painful that is, this procedure? Enzymatic debridement is similar, but it uses a topical agent to dissolve and remove necrotic tissue and lift eschar. So you apply this agent in a thin layer within the wound area, and you cover it with one layer of fine mesh gauze. A topical antimicrobial agent is then applied and covered with a bulky wet dressing, and the wound is immobilized with expandable mesh gauze. Once the eschar is removed and granulation tissue appears, the enzymatic agent is discontinued. So after the wound has been cleaned and debrided, it can be dressed by one or two methods. In the open method, the wound remains open to air. You've all seen that, those of you on surgical units. And it's covered only by a topical antimicrobial agent. So an advantage of this method is easy access to the wound, but a disadvantage would be that those topical agents tend to rub off on the bedding and require reapplication. The open method also increases the risk for hyperthermia. The closed method involves the application of a topical antimicrobial agent to the wound site, and then the site is covered with gauze or a non-adherent dressing and wrapped with a gauze bandage. With the closed method, wounds are usually dressed twice daily or as needed. This method decreases heat loss, but may impair range of motion. So on D2L, under the supplemental area, I have included an information sheet related to biological and biosynthetic dressings for those of you that have this burning desire to know more about burn dressings. But again, I kind of step away for that with testing because this type of care is specialized, and for an entry level nurse, I'm not so sure knowing biological and biosynthetic dressings is something that you need to, know, but you should know the open and closed method of wound dressing. So the patient with a major burn is in a hypermetabolic and in a catabolic state. Their resting energy expenditure after a severe burn can increase as much as 100% over normal levels. That means they're burning calories as fast as they can take them in. So as a result, their total caloric needs may be as great as 4,000 to 6,000 kilocalories a day. So if you want to put that in perspective, if you think about it, those of you who have been on a diet, they want you to stay between, I don't know, 1,200 kilocalories a day to lose weight. These people have to consume 4 to 6 times that amount. And that's just to maintain their weight. Without an increase in their caloric intake, they're going to lose weight. And that's, that's not good for nutrition. So again, oral intake is often supplemented with enteral feedings with a nasal intestinal feeding tube, initiated within 24 to 48 hours after a burn. A nasal intestinal tube, and I didn't say nasal gastric, I said intestinal, is placed under fluoroscopy with the tip extending past the pylorus to prevent reflux and aspiration. Enteral feeding is the preferred nutritional therapy, but it is contraindicated with curling ulcers, bowel obstruction, feeding intolerance, pancreatitis, and septic ileus. When an enteral route cannot be used, a central venous line is inserted for TPN administration. You want to, as the nurse, observe and report any evidence of feeding intolerance, such as diarrhea, vomiting, excessive gastric residual, abdominal distension, absent bowel sounds, and constipation. So for those of you who are now on a clinical unit where you're doing frequent, they have tube feedings or they have peg tube meds, when you check for residual, you're doing that because you're checking for feeding intolerance. Again, diarrhea is a big one, vomiting, distension, listen to your bowel sounds, and constipation can also indicate a feeding intolerance. We want to weigh this patient daily, and weight indicates the adequacy of nutritional support. We want to obtain and monitor lab values. So what lab values are you going to be looking at for nutrition? Anyone?
Albumin.
Albumin.
Yes. That TP you see on your lab sheets, total protein, that's another one. So again, total protein, iron, CBC, glucose, and albumin. That would be a good one. Then they're going to indicate whether there's adequate nutritional intake. Good. 2 more slides. The last and the final phase of burn care is the rehabilitative stage. It begins when most of the burn area has healed and ends when the client achieves the highest level of functioning possible. Priorities include preventions of scars and contractures, psychosocial support, and resumption of activities. One treatment for the prevention of scars involves the use of pressure garments. And so I have included some information on pressure garments on D2L for your review. And so I truly want you to, and you can see, I think in this bottom right, this patient here has a pressure garment on. So please take the time to review that. Know that the rehabilitative stage, it can last for years. So let's do a little question here. A patient who suffered burns of the lower extremities is ordered a high protein, high calorie diet. Move this out of the way. A food diary reveals that the patient is not meeting protein or caloric intake goals recommended by the dietitian. The patient tells the nurse of feeling full quickly when eating meals. Which interventions should the nurse recommend to the patient? And this is one of those select all that applies. So let's go one by one. Do you want to choose number one?
Yep.
So actually the answer is no. Fresh vegetables contain needed vitamins, but they're not good sources of needed calories or protein. So we'll throw that out. How about eating 5 to 6 smaller meals instead of eating 3 larger size meals?
Yes.
Yes.
Yes, right? A patient is more likely to increase their intake if they eat more frequent meals. And she said, or he said, that they feel full quickly. What about the protein bars and the whole milk yogurt as snacks?
Yes.
Yes.
Yes, very good. Protein bars, whole milk yogurt, and protein supplements are good sources to add calories and protein. What about drinking regular instead of diet sodas?
No.
No, remember, soda. Simple sugar is not a source of protein and lacks other nutrients. And what about adding protein supplements to cooked cereals?
Yes.
Yes.
Yeah, very good. So easy peasy on this one, right? Any questions? And actually, I think I do have some questions. I'm going to stop the share here. And I'm going to go to the polling because I have some questions. So I'm going to launch my poll and allow you to complete it. Can you see the poll?
Yes.
Go ahead and complete it. Does it allow you to complete it? Okay, so let's go over that. I know pain is, something you actually you monitor and you want to, manage, but it is not the priority. And so the pulse ox is good, so we're going to disregard that. What about these vital signs do you think would be the priority? Because temperatures as 100, that's normal. Pulse rate is normal. Respiratory rate is a little high, could be anxiety or it could be the pain. Blood pressure, fine. So I kind of, they're kind of benign. This output is the answer. With a normal person, or not normal, but a person that doesn't even have an injury, you want 30 mLs an hour. So this is a burn patient, and we're not getting 30 mLs an hour. We're getting less than that in 2 hours. So that would be the answer. So I'm going to give another poll here. So let's get out of here, go back to my polling, and cancel. I did this, stop sharing. Right, it's not letting me to go to the next question, so let me just try again. Oh, here it is. Okay, I'm going to give another one. Can you see it? I apologize for asking all these questions. I can't see what you see. Can everyone see this?
Yeah, like a.
Yeah.
Good, thank you. All right, let's go over them. So again, the answer is encourage the client's family to bring favorite foods. We would, let's look at the second choice. We don't want a low fat, low cholesterol diet, right? We want a high calorie, high protein. So we would throw that out because it doesn't meet the requirements. And then when it says monitor the weight weekly, we monitor the weight daily. And then the referral would not be to a hospital social worker, but to a nutritionalist. So let's end that poll and go on to the third one. And I'm going to launch it. Are you able to see that?
Yes.
Yes.
Okay, good. All right, let's look at this. We'll talk about, so a xenograph is skin obtained from an animal, usually a pig. Very good. From a donor would be an allograft, the skin from yourself, an autograft, and then again, we never turf things off to the doctor. If you should be able to answer this question. Very good. And so let's move on to the fourth. And let's launch. So very good, it is. Remember, changes in lifestyle take time. And we don't want them to stay at home, right? That just increases depression and anxiety. And then, of course, you want them to rely on their support systems, their family, their friends, their neighbors. And then, again, they should be able to discuss their feelings with everyone, not only a therapist. I think I have two more questions here. So you're right, it's superficial partial thickness, very good. we have that blistering that kind of moves it off of the superficial into the partial thickness, and then there's the deep thickness. ATI has an excellent little chart on there which describes the different types of burns and the treatment for same, so, and what it looks like. So I would definitely suggest that you take a look at that if you have time. And your textbook also has it. So I am going to just share my screen one more time and briefly go over a case study that I did. So let me. Back. Trying to escape out of here, which is impossible. Alrighty. So let's share screen. I want to go to Word. Nope. Desktop share here. Case study open. All right, can you see my case study? Is everyone able to see a case study? Good, let's just start. It shouldn't take us more than 5-10 minutes, but I think it's important that we talk about this. So we have Fatima, a single 32-year-old Muslim refugee female who has been living in the United States for 6 months with her 2 kids in a garage. She was, pardon?
I don't see the case study on my screen.
No.
I don't see it either.
You
I
cannot,
see carbon hemoglobin levels are typically lower than 2%. That's what I see.
okay, let me fix it. Alrighty, so if I start share, burned. Oh, you have my stickies. Now can you see it?
Yeah, we do
Yes.
now.
Okay, so sorry about that. I got more stuff on this laptop than I care to share. So we have a young 32-year-old Muslim refugee female living in the United States for 6 months with her 2 children in a garage. She's cooking dinner to break her when a glass leak resulted in an explosion. Her children were out playing in the front yard when they heard the explosion. Her eldest daughter immediately ran to the neighbor's house and asked them to call 911. Upon arrival to the scene, firefighters rescued Fatima and emergency technicians were able to remove her burned clothing. She was conscious, alert, and oriented, but sustained significant burn injuries to her face, neck, interior torso, bilateral upper and lower extremities, and posterior trunk. How do you want to manage her airway? What do you want to do? Look at these injuries.
Intubate him.
Intubate.
Right, you need to take control of that airway because of where they are. Face, neck, that face and the neck are the big ones because the suspicion is that burn now is going to turn into this massive adenomous tissue and you would block her airway. So you need to take it as quickly as possible. So very good. We are going to take her airway. The EMT started an 18 gauge in the left forearm and initiated an intravenous 1,000 milliliter bolus of lactated ringers. And so why did they choose the lactated ringers?
Mimics extracellular fluid.
It is closely relates to the extracellular fluid. Exactly right. So yeah, that is the thing of choice. So now the EMTs radioed in their estimated time of arrival at 10 minutes, and the West Hills Trauma Medical Team and burn personnel are informed. Initial assessment at the hospital revealed a young woman that was orally intubated with bilateral clear breath sounds. So here's her vital signs. Heart rate is 120. Expected?
Yes.
Yes. And what would you say why it's elevated?
The body's in the compensation phase.
So why is the blood pressure still high?
Because the body's still trying to compensate, like, so it's the sympathetic nervous system, is it? It's just
So-
speeding everything up.
Fluids.
So what would speed everything up initially? And you're right about the sympathetic, pain, anxiety, right? You're going to see an increase in that heart rate, maybe not because of volume deficit, but because of what's going on. Her pressure is high. Remember, I said it takes about 30% of your total body fluid to be absent before you're going to see a drop in blood pressure. So that's really not a good indicator of fluid volume. But in this case, I would say that it's elevated because the sympathetic nervous system is in that fight or flight. Very good. Temperature here appears normal. The CPOT, does anyone know what that scale is? It's a scale that it's a behavioral scale that you would use on someone who's intubated. And when I say intubated, this patient has also been paralyzed and paralyzed and medicated. So she's not able to tell you what her pain is. So they look at behavior. And you may have seen it again on a surgical floor or on 3D, those who use on 3D where they're intubated, they would use this scale. Respirations are 18, and that means she's on assist control, and that's the respirations that they set on the ventilator. And there's her O2 sat is 97%. So we're actually managing that airway quite well there. So the sustained burns to the face, the neck, the torso, the bilateral upper and lower extremities and posterior trunk were classified as full thickness burns. And we're talking about 51% of her body. We did a chest x-ray. We confirmed accurate placement of that ET tube. And so now we want to start fluid resuscitation. The following initial labs were drawn. We did a CBC, a carboxyhemoglobin, electrolytes, and ABGs. Would you insert a Foley catheter now?
Yes.
Yes.
I'm going to tell you that this is the one, you know, how we kind of shy away from inserting Foleys. In a burn patient, a Foley catheter is very clearly indicated because we have to see if our fluid resuscitation is effective or not. So yeah, you would. She's transferred to the burn intensive care unit and fluid resuscitation is continued. Her reported height and weight were 157 centimeters and 50 kilograms. So let's look at this Parkland formula. I said that her total body surface area involved was 51%. So we're going to take 4 times the 51% times her kilograms, and we're going to get what?
10,200. Right.
Perfect. And so these would be like the type of question that I would ask. I'm giving you just basically everything. So you're right, 10,200 meters in the first, that's 10 liters of fluid in the first 24 hours. That's a heck of a lot of fluid. So the first half are going to be administered in the first 8 hours. And so what is that going to total?
5,100.
Perfect. And then the second half is going to be given over the total of the last 16 hours. So what are we going to set our pump at? What's left? So I gave 5,100 in the first 8, and now I have to give another 5,100 in the next 16. So how do I figure out what I'm going to set my pump at?
318.8 ml per hour.
Exactly right. Good. So here's her vital signs now. We have a heart rate of 115 coming down. Look at that blood pressure drop. Temperature, hypothermic, right? She's going towards hypothermia, which is expected. That's why we try and keep them warm. She's 3 points on the CPO2. So that's a 3 would be a high pain level, and that would be by, her behavior. Her respirations are 17 and her SAT is 98. So hourly vital signs are documented. We have a continuous hydromorphone drip at 1 milliliter an hour. Why did they choose a continuous drip rather than a PCA pump?
Because she's unconscious.
Good.
Yeah.
So when you see that in a question answer, I mean, PCA pump, and if they're telling you they're on a ventilator assist control, then you have to kind of figure that they can't push that button. So she was assessed for any signs and symptoms of respiratory distress. An NG tube was placed for nutritional needs. Output urine output was 40 milliliters an hour. So in adult patients with burn injuries, urine production of 1 milliliter per kilogram is considered accurate. So let's say she's, what was she, 51 kilo? What was her weight? I'm trying to see. 50 kilograms, right? So
Yes.
she was 50 kilograms. And so if we take the higher limit of 1, she should be putting out 50 milliliters an hour, right? Of urine. Is she putting out enough urine? Is that accurate? Is resuscitation effective?
No.
No.
No, I think she probably needs more. So let's look at lab results. We have a high K and a low sodium. Remember, these are the things you got to remember, your K and your sodium. So explain that K level.
High.
It's high
High.
because there is excess potassium in the cells and the sodium is out of the cells.
Right, so the sodium has leaked out of the cells. It is in the serum now, and we have a high potassium level. What about the sodium level? It's low, right? And I said, and again, I'll go back to what I said before, the sodium has moved into the interstitial space. So we have a low serum sodium because sodium and those large proteins is now in the interstitial. Carboxyhemoglobin is at 11%. So a little bit about carboxyhemoglobin. Levels are typically lower than 2% in non-smokers. And then smokers, they're lower than 5%. A level over 9 is almost always due to carbon monoxide exposure, even among smokers. So she's high at 11. So again, you really want to, she's on a ventilator, you want a ventilator with 100% oxygen. You want to push that carboxyhemoglobin molecule off of the hemoglobin and restore it with oxygen. She's right on that borderline of meeting the bariatric, the chamber at 15%. So again, you could consider using that. So while she's in the BICU, she has received multidisciplinary care from nutrition, respiratory, spiritual care, physical therapy. So once she Once the patient was stable, she underwent serial surgical debridement. So what's surgical debridement? Anyone? Surgical debridement is right when we actually go in with
Cutting away the necrotic tissue.
yes, cutting away. What would be a form of mechanical?
Like with scissors.
Mechanical
Or-
would be that wet to dry, remember? And then the table, the spray table, and enzymatic would be the topical agent that they would place. All right, the healthcare team proposed a porcine xenograph as part of her palliative care. However, due to conflicting Islamic religious beliefs, the plan of care was revised. After consulting with Fatima and the mullah, they both agreed to a Hala bovine xenograph for treatment. So what is a heterograph or a xenograph?
From an animal.
From the animal, usually a pig, but there are Hala, I hope I'm saying that right, bovine xenographs, where they use an animal that is acceptable to that faith. So the importance of doing this is that if you're going to do any, when you treat patients, your plan of care has to encompass their religious beliefs and their cultures. What is a culture epidermal autograph?
From yourself. Human skin.
Yes, they take the cells, right, and grind them
From a
up.
cadaver.
Yes, they grow it. When you think of the word culture, when you take a sample, they actually take a skin sample from a healthy portion and they mince it up and then they can grow it, and they grow it in sheets, and over I think it's like 3 to 5 days or several weeks, you can grow enough skin to cover an entire human body. So why is it critical to initiate fluid resuscitation in burn patients? Because of that initial shift of fluid, right? Happens in that first hours after a significant burn. So we've lost volume, it's in the interstitial. So in order to have an adequate cardiac output, we need to replace that volume. So again, how would you address her cultural beliefs and what type of support systems could be integrated in this patient's plan of care? And I would always say, again, a very important factor that is commonly and widely ignored is to the extent to which a patient's faith or belief may influence their choice of, again, with burns, biomaterials, and the way that their plan of care is organized. So again, always address that. That is as important as taking a blood type on someone. So she had 51% of total body surface area involved. So why is it important to calculate that total body surface area in burn patients? Why do we calculate it?
In order to find out how much fluid it needs to put back in.
Very good. It determines the amount of fluid resuscitation. Very good. I know that there's an increased mortality with a percentage of total body surface area greater than 50%. So I'm going to stop sharing here. I think I've kept you long enough. Does anyone have any questions?